Good evening, and welcome to another edition of Housecall. I'm Dr. David Doman. Do you have any questions about the COVID-19 vaccine? Find out more right now. My guest this evening is Dr. Barney Graham, Deputy Director of the NIH Vaccine Research Center. Dr. Graham, welcome to Housecall.
Thank you. I'm glad to be here. Thank you for inviting me.
Our pleasure. So briefly tell our viewers about your professional background.
I've been at the VRC for 20 years. It was opened in 2000. Prior to that, I was at Vanderbilt University, where I did internship, residency, and was on the faculty for over 20 years. And prior to that, I went to medical school at University of Kansas. And I should have mentioned I got a PhD in addition to that at Vanderbilt. So undergrad was at Rice University.
What specialty did you pursue in medicine?
I'm an infectious disease physician.
Yeah. Okay. All right. So, which will be interesting since we'll have our own specialty perspectives on the topic tonight between your background in infectious disease and, of course, I'm a gastroenterologist. So, in any case, for our viewers that don't have a science background, explain briefly what exactly is a vaccine.
A vaccine is something that we manufacture or produce, that it's a substance that will resemble vulnerable targets on a pathogen. So usually it's a protein. Sometimes it can be a carbohydrate, but it's something we give the body. We inject it usually, or sometimes we give it nasally. And when your body sees those foreign surfaces, those foreign shapes, it's able to recognize that and make an immune response, either with B cells to make antibodies or T cells that can clear the virus infection.
So it enhances one's immune system to attack a virus.
In short, it teaches your immune system what is a pathogen, what is a invader, what is foreign.
It's very helpful because many people out there think that COVID-19 is a bacteria and we're treating it with antibiotics, which clearly is not the case.
Right. COVID is caused by a virus, a coronavirus called SARS-CoV-2.
So how long does it typically take, in your experience over the past decades, to develop a typical vaccine?
Most vaccine development programs are measured in decades, not in years. And so going as fast as we did this time is pretty unusual. I think this is a new record.
And of course, the journalists have been describing phase 1, phase 2, and phase 3 clinical trials. You and I are acquainted with that terminology, but explain briefly to our viewers what exactly is a phase 1, phase 2, and phase 3 clinical trial.
Right. One of the reasons vaccine trials and vaccine development often take decades is because things are done serially, and you go very deliberately between animal studies that justifies starting a phase 1 trial. Phase 1 trial usually involves a few dozen people, and you are looking for whether the vaccine is safe primarily. You also get some information about whether it makes the kind of immune response you're expecting. Phase 2 trials are usually in hundreds of people, and they're usually more to adjust the dosage of the vaccine, look for more safety information before you go into larger trial, phase 3, which is usually done in thousands and thousands of people. Because the phase 3 trial is looking for whether the vaccine works or not. So you have to immunize enough people in one group and have a big enough placebo group that you can have enough cases to make a judgment about whether the vaccine works. And of course, it also gives you a lot more safety information.
So given these 3 phases of a typical clinical trial to get a vaccine approved, what can you tell the public about Operation Warp Speed, how you truncated everything to less than a year and have now launched at least 2 vaccines with more to come?
Yes, Operation Warp Speed is an interagency infrastructure that was put in place, administrative infrastructure that would facilitate vaccine development. It includes a number of groups to give oversight to vaccine development, to vaccine manufacturing, and vaccine distribution. It also has another component that is helping to develop antibodies and other treatments. And it includes a consortium of networks, groups that have been testing HIV vaccines or influenza vaccines or a lot of the other vaccines in development. All of them came together as a large consortium group to work together to rapidly do this coronavirus vaccine testing. So Operation Warp Speed is largely an administrative infrastructure, but also brought along a clinical trials network and a lot of experts who can advise the companies. And of course, it also came with a lot of money. And so the large amount of funding that was provided to many of the companies doing this is what allowed them to take the risk. Usually the decades of work is spread out in a serial sequential fashion because you don't want to take the risk of the large expense of the next study until you've gotten all the information from the prior study. In this case, because there was so much money available, the phase 1 and the phase 2 and the phase 3 in some ways were overlapping. After you got the essential safety information, you could go to the next stage, and therefore you could do a lot of things in parallel and get to the phase 3 trial very quickly.
My understanding is that vaccine studies, typically, if there's going to be significant side effects, are identified during these trials within 6 to 8 weeks. So therefore, do you feel that Operation Warp Speed afforded adequate monitoring for safety? Because many people who are reluctant to take the vaccine are worried that Operation Warp Speed may have compromised safety.
Right. Many people are concerned at not only the term Operation Warp Speed, but the fact that we've been able to go so fast, and they wonder why or how we've been able to go so fast and keep things safe. And as you said, almost all vaccine side effects are obvious within 8 weeks. And that's one of the reasons the FDA made a requirement that you had at least 8 weeks of follow-up on at least half of the people who've been immunized in the large trial before they could even consider an emergency use authorization. And so we, of course, in many cases would have a lot more information on duration, durability of the immune response and things like that. But in this case, because of the urgency, we've truncated that, and we're now gathering a lot of safety information as we immunize people. I think there's over 10 million people now who've been immunized, and as that process goes forward, a lot more safety information is being collected.
So given that vaccines do appear to be safe, what are some of the side effects, and what is the preliminary thoughts about the rare anaphylactic reactions that have been reported?
There are some people who have had allergic type reactions after the vaccination. Usually they notice something very within a few minutes after the first injection. And that's happening a couple of times out of a million. And so the way I think about it is that is a risk, especially in people who are highly allergic. Many of these reactions have happened in people who already carry EpiPens and know that they're highly allergic. And so it's important, if you have concerns about allergies, to not only talk to your local provider, but to do your vaccination in a setting where you can be cared for if you do have an allergic reaction. The typical reactions that people are getting, I can talk more about the mRNA vaccines, but many of these local side effects are the same. You can sometimes get a sore arm, you can sometimes get pain from the injection, and sometimes get some redness at the injection site. So those are called local reactogenicity, local reactions from the vaccine. And it's similar to what many people experience with the flu vaccine. And in the case of mRNA, it's a little worse after the second injection. So the second injection brings in a larger immune response because you're boosting the immune response. And we think those reactions are largely due to the immune response that we want to generate. So it's not an unexpected type of side effect. In addition, there's systemic reactogenicity. That means things like fever or headache or muscle aches can occur. And that's also something we expect in some individuals, especially after the second dose in the mRNA vaccines. Reactions in the adenovirus vector vaccines that are coming along, most of those local reactions are worse after the first dose and not after the second dose. So there's a little bit of difference in that profile between vaccines.
There's a misinformation out that if you get the vaccine, you can actually get COVID-19. How do you reply?
A lot of people have said that kind of thing about flu vaccines over the years. And of course, the flu vaccines, most of them are inactivated. They are not live viruses, so you're not being infected. When people get what I was mentioning, the systemic reactogenicity, maybe a little fever, muscle aches, and things from the immune response, that's what they associate with flu or influenza infection. So even though you're not being infected, you can have some of those side effects for a day or two, but that's not an infection. And so in this case, we're only giving about 12 to 15% of the overall virus. The coronavirus is a large virus. The spike protein, which is the big protein on the surface of the virus that helps it get into the cell, is a small part, a little over 10% of the virus. And it by itself cannot divide and grow and replicate. So it is not a virus infection. It's just exposure to this important protein that the virus uses. And we want to attack that protein with our antibodies.
You mentioned several times mRNA, which of course stands for messenger RNA. We have a minute left before we go to break. Can you briefly explain to the viewers what exactly is messenger RNA?
Messenger RNA is something that's in all of our cells. Every cell in your body makes its own messenger RNA. It's how our genome, it's how our genes in the nucleus of our cells tell the cell what kind of proteins to make. So messenger RNA it comes off of the DNA in our cells. It goes out into the cytoplasm of the cell, and it is what gives the code or the message to make a protein and how to make the protein, what order of amino acids to use in making the protein. So messenger RNA is what the cell uses to make proteins. In this case, we're asking the cell to be the factory. Instead of making these vaccines in a building, we ask the body itself to make the vaccine. So we give the messenger RNA, it goes into the cytoplasm of your cell, and then your cell makes the spike protein, and that's what elicits the antibody response to protect you from the virus.
How interesting. We're going to pause briefly for a public service announcement. More with Dr. Barney Graham and the COVID-19 vaccine in a moment. We'll be right back.
Here are AARP's top tips on caregiver preparedness during coronavirus. Form a caregiving team. Inventory essential supplies and medications. Make a plan to stay connected. Maintain self-care and follow CDC guidelines. Learn more on our website.
We're back, and my guest this evening is Dr. Barney Graham, Deputy Director of Vaccine Research at the National Institute of Health. Dr. Graham, given now that we have at least 2 and hopefully more vaccines to be distributed globally, explain to our viewers what is the rationale for so-called vaccine-induced herd immunity. What are the benefits?
Herd immunity is something I like to call population immunity or community immunity. It's how we take care of each other. It's how we protect each other. And the idea is that the virus is able to spread because there are susceptible people around us. There's people who don't have immunity, they're susceptible to the virus infection. What happens in population immunity is if you have enough immunized people surrounding each infected person or surrounding each uninfected person, then that virus doesn't have an easy way to get to that person who's still susceptible. It's either blocked by the people around the infected person or the chain is interrupted by the people around the uninfected person. And so eventually we're all going to be infected with this virus or immunized by the virus with a vaccine. Within 3 to 5 years, I would say every single person on most everybody on the planet is going to have immunity against this virus. I think the decision people have to make is, are you going to get immunized by infection, where you may have a 1 or 2% chance of dying, or maybe a 10 or 15% chance of hospitalization, or are you going to get the vaccine that gives you a few out of 1 million chances of a side effect, of a serious side effect? So I think that's the decision everyone has to make. The herd immunity is something that we're going to reach eventually, and that will make it harder for the virus to spread between people, and so the transmission rates and the prevalence of the virus in the community will go down.
Now, of course, the fundamental role now of the vaccine is prevention, or at least ameliorate illness if somebody does get infected. But is there any research going on about using it as a therapy? Somebody acquires COVID-19, they're hospitalized. Is there any role for giving vaccination at that point to try to blunt the effect of the virus?
There are some types of therapeutic vaccines that are being used. There are some therapeutic vaccines that people use, for instance, for cancer. It's in settings where you might have a chronic condition and you're trying to change the immune response that could unlock that chronic condition. You could use a therapeutic vaccine, but in this case, especially for acute viral infections like this, vaccines are used for prevention. You have to give it before the infection to have an effect. If you're already infected, the vaccine won't necessarily help you get immunized faster. Now, what we can do, what we want these vaccines to do is induce an antibody response. And so your cells can make antibodies that could cover the spike protein and protect you. Well, we can find antibodies like that. If we take cells from blood, we could We can search them and find antibodies that can do that. And we can make them in a factory. We can give people antibodies directly, what we call passive immunization, and we can treat them. So the antibodies that have been tested so far have been shown if you have early in disease, symptomatic disease as an outpatient, giving an antibody treatment to rapidly reduce your amount of virus can help you avoid hospitalization. It can reduce the progression of disease. And so vaccines in this case would be preventive, but there are therapeutics that would take advantage of what vaccines can make, which is antibodies.
So a viewer has been vaccinated. They received their 2 vaccinations. Can they let their guard down and stop wearing a mask, stop social distancing, stop frequent hand washing? Or should they continue those precautions, and why?
Well, I want everybody to consider the idea that we're all in this together. Not just our neighbors in the US, but the whole world is in this together. This virus is going to go wherever there's a susceptible person. Just like the concept of herd immunity, the vaccine is intended to protect you as a person and keep you from getting severe disease, but also to protect people around you so you can start helping the community to interrupt transmission. So if you're vaccinated, that means that you may not be susceptible to severe disease, and that's good for you. But since we're all in this together, and since you might be able to still be infected, especially in your nose, maybe not in your lung, but in your nose, you could maybe still be an asymptomatic carrier of virus. And so if you're going to try to protect your immunity, protect your community, you're going to still have to wear a mask. You're still going to have to be careful. I think until the overall virus load in the community goes down, which I'm hoping will happen this summer. I don't know when it will happen, but most coronaviruses that come around every winter are pretty much gone by the end of May. I'm hoping if we can get enough immunity in the population that would be true of this virus as well, but we don't really know how it's going to behave. It depends on how many people are vaccinated, and it depends on how careful we are. But if everybody continues to wear masks and keep their distance, wash their hands, and do the things that Dr. Fauci has been preaching about on national TV, then we can get the amount of virus in the community down and start resuming our lives together. But I think when we take the masks off, it should all be done at the same time together.
I agree, which leads to a question that many of our viewers are wondering. In plain English, when will we get back to normal? When can we go to the Kennedy Center for a show? When can we go to a ball game to watch the Nationals play? When can we go to a movie theater? It's an inexact science, but when would you predict those things will come around?
I'm hoping, this is my hope, this is not what I know, this is what I hope, but I can get 300 million of Americans immunized, either through infection or vaccination. I'm hoping it's vaccination. Then we're going to be in a position where there's enough immunity that it's going to make it hard for the virus to spread. And so when we can hit that point, I think that's when we might start seeing the virus get to a place where it's hard to spread. There's enough immunity that it may not cause a severe disease. The amount of virus you're infected with may go down as well. And so when that time comes, I'm hoping it comes sooner rather than later. Like I said, I'm hoping it could be by the end of May if everybody can get vaccinated, if enough people can be vaccinated. It might be later this year, and it may have a little surge next winter, like most coronaviruses come back during the winter months. And so I'm hoping that by the end of this summer, maybe we could have some normal life again. That's what I'm looking forward to. But
Great.
it's only it's only if we remember that we're all in this together. You can't do that just with some individuals doing it one way and other individuals ignoring it.
Right. Now, the two vaccines that have been released to date, Moderna and Pfizer, claim a 95% response rate. So let's focus on the 5% who don't have an adequate response. One question I have is, to my knowledge, it's not recommended after you get the 2 vaccination injections that you have your antibodies tested. So how can you tell whether you're part of the 95% responders or the 5% non-responders?
Yeah, let me clarify some things. So far, at least in the both young and older people we've tested, at least in the phase 1 and 2 trials, there's been 100% response rate in terms of making antibody. So almost everybody, virtually everybody I've seen so far has made an antibody response that could have some level of protection. Now, if you divide up the people who got vaccine and the people who didn't get vaccine, in the earlier phase analysis, when the FDA made its decision about emergency use authorization, there was 196 infection cases in the Moderna trial, which I know best. And of those 196 cases, 185 were in the placebo group and 11 were in the vaccine group. And that's where the 95% calculation comes in. You have a 95% less chance of being infected or symptomatic if you have been vaccinated. And fortunately, of the 30 severe cases where you had either really low oxygen levels or hospitalization, in that case, all 30 of those cases were in the placebo group. And it's true in the other vaccines as well, in the other mRNA vaccine, Pfizer, and some of the adenovirus vaccines we're hearing about, and even some of the vaccines that are less effective. Everybody who's been immunized or vaccinated, it's very rare to see a severe case, severe disease in those individuals. Even if they might have an infection that has symptoms, very, very rarely does it become severe.
So even in the 5% of so-called non-responders, they do mount some sort of an immune reaction.
Right, those people mount a reaction and they're partially protected. They end up with a low-grade cold-like syndrome, not a severe case where they end up in the hospital.
Okay. Taking a page from our experience with the flu vaccine, do you feel that we, at least for the next few years until we learn more about the virus, will need to get an annual vaccination for COVID-19, perhaps modified for any mutations that may develop down the road? And we have 1 minute for you to respond.
Okay. This virus is going to be changing. It's an RNA virus. It's based on RNA genome. So it will change, and we're seeing some of that reported in the newspapers. It will not change as much as the flu virus changes. It changes much more slowly than the flu virus. But we don't understand it very well yet. Right now, we think that these vaccines will easily last through 1 season or 1 year. I don't think we know enough about it yet to know how well they'll do during the 2nd or 3rd year. And I don't think we know yet enough about how the viruses are going to change to know whether we may have to replace the vaccine with a new upgraded vaccine to protect the new strains. But a lot of that work is being done now in great earnest.
Dr. Graham, we're out of time. I feel I could have interviewed you for another 2 or 3 hours. Thank you for joining us on Housecall. My thanks to my terrific team here at the studio. My thanks to you, the viewer, for joining us at home. Let us know how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, we anticipate having a guest from the Montgomery County Health Department, and they'll be discussing the practical matter of COVID-19 vaccine deployment, all the challenges therein. It's going to be an obvious, important show. See you then next time for another edition of Housecall. Good evening.